So what we're going to do this evening is to talk a little bit about healthcare reform in the United States. And I gather this course has probably talked about this before. And what I'd like to do tonight is actually contrast the Affordable Care Act with a single-payer approach to healthcare reform. And what we're going to do is start by talking a little bit about the politics of the ACA, how it came about, and what are some of the features that became important in it. Then just list the challenges that we face here in the United States with our healthcare system, and then taking each challenge, compare the policy options we have with the ACA versus a single-payer approach. Now, I don't know how many of your lectures proceed with a disclosure. Is that required here? Even the chemistry lectures and biochemistry? They should, I think. But I want you to know that I have no relevant financial relationships with commercial interests that shaped this talk, but as you heard, I have been involved with an organization called Physicians for a National Health Program. However, I have received absolutely no compensation from that organization. If anything, I have contributed money to it. So, I believe that President Obama had a fateful choice at the outset of his presidency. He really wanted to do something about healthcare. A lot of people advised him not to do this in his first 2 years, but no, he was very firm that he wanted to, and he did not want to start from scratch. And he was absolutely right, I think. He wanted to build on existing healthcare programs in the United States, but he did have a choice, I believe. And that choice was whether he would build on the private sector, private health insurance and what have you, or build on the public sector, such as the Medicare program. Which do you think he chose? Anybody have a guess? You're not going to be marked. Come on. What do you think he did? Yeah, I'd say that he probably did indeed decide to build on the private sector. And he was following in a tradition, though, that's kind of interesting to sort out. For instance, here's the first president that advocated national health insurance for the United States while he was sitting as president. Does anyone know who that president was? I don't expect any of you to recognize the face, but anybody have an idea of who that is? Yes?
Harry Truman.
Harry Truman. There's a historian in the crowd. Well done. Exactly. Did he get his national health insurance program? No. So it was left up to this chap here. Anyone recognize that face?
Johnson.
That's LBJ, right? And when he was elected president in 1964, he decided to take the Truman concept and in fact make it a concept that would apply to a limited population, namely those over 65. And that's how we got the Medicare program. And then in the early 1970s, a non-president, anyone know who that is? A senator from a neighboring state. That is Ted Kennedy, the head of the Help Committee in the Senate. And he said, let's take this Medicare program and spread it to the entire population. But the sitting president at that moment, this guy up here, Anyone recognize him? This was early 1970s.
Nixon.
That is Richard Nixon. And Richard Nixon said, oh no, we're not going to take the Medicare program and spread it to the rest of the population. Let's just insist that every employer offer health insurance. Did Nixon get his employer mandate? Any idea? No, he did not get the employer mandate, so it was left up to this guy. Anyone have an idea of who that is?
William.
Pardon? Bill Clinton, right? And Clinton decided to not only think in terms of an employer mandate, but more importantly, an individual mandate. Which is and I don't know if you can read this, if there's, but he really had an individual mandate in his legislation. It said each eligible individual must enroll in an applicable health plan for the individual and must pay any premium required to with such enrollment. That is a real individual mandate. Did Clinton get his individual mandate? No. And so it was left up to Barack Obama to decide to combine these two ideas, an employer mandate and an individual mandate. But in order to make that a little bit more palatable to the public, he came up with the idea of a public option. You can choose to enroll in a new public plan. I don't like the Cornell health insurance plan. I could decide to enroll in this new public option. Oops, sorry. Well, what was this public option? The original robust plan, which was put forward in March of 2009, and I had the fortune actually of being at the White House Healthcare Summit where this plan was initially articulated, was a plan in which there was open enrollment in Medicare for anyone who wanted it. It would be simple and efficient because Medicare had in fact negotiated rates with every hospital in the country, and virtually every physician, about 90 to 91% of physicians take Medicare. And it would be backed by government, so it wouldn't have to put aside a whole lump of reserves the way a private insurance company does. And, you know, along comes this entity, Lewin and Associates, interestingly owned by United Healthcare, one of the largest private insurers in the country, and it estimates that 119 million people will enroll in this public option. Oh, wait a moment. How many uninsured people were there in the United States in 2009? Does anyone have a guess? About 50 million. Some people say 48.9, but 50 million. In other words, there would have been a lot of people like me who might have said, I didn't like my Cornell plan, that would have actually enrolled in this public option. Realize that the public option is not a single payer program, however, because in fact, there would be multiple payers that would still exist. So what happened? Well, along comes the insurance industry and the pharmaceutical industry, and it spent in the year 2009 alone $1.2 billion in lobbying to, in fact, defeat the public option. And this is not just my saying here, I don't know, you can't quite read it, but this is from the Center for Public Integrity that made this, in fact, estimate in March of 2010. So what happened? Well, the House plan, which was passed in the House of Representatives in 2009's November, had very, very restricted enrollment. You had to be uninsured before you could, in fact, get into this public option. And the Congressional Budget Office went out and estimated that only 6 million people would actually enroll in such a public option. And the legislation required that it negotiate rates with every provider, doctor and hospital, and put aside reserves. In other words, it would have to behave like a private health insurance company. Well, even that was too much for the Senate. And I remember this vividly because the Senate passed its plan on December 24th, Christmas Eve, if you can imagine. And it had no public option in it. Little wonder, because the person who was the architect for the Senate plan was Liz Fowler. Has anyone ever heard of Liz Fowler? I certainly hadn't. Maybe Ellie has here, but I had not. But Liz Fowler was the former vice president of WellPoint Insurance, probably the second largest health insurer in the country. And little wonder that she did not want to see a public option in this plan. Well, then there was a political event that occurred, an election, in January of 2010. Anyone recall an election in actually one of your neighboring states? No one has this history in mind. Ted Kennedy had died. His position was up for election, and Scott Brown was elected. And who was Scott Brown? But a Republican. And the result was that President Obama lost his 60th vote in the US Senate. Because as you know, what usually happens there is that you need that supermajority to get something passed. And what usually happens in Congress when you have two bills that come out of the House, one out of the House and one out of the Senate, and they differ, the Congress creates a conference committee and they negotiate. And it might have been that if in fact he had the 60 votes, Obama might have been able to get his public option. But what happened here was that he knew that if he went back to the Senate with a public option in it, it would have been turned down. So he took the Senate bill and forced the Democratic-controlled House, in essence, to vote on it. And that's what gave us the Patient Protection and Affordable Care Act. We used to call this PPACA, but everybody now calls it ACA. And you can see it took a few months for him to get this through Congress. And what is the ACA? Well, it's a pretty complicated act when you look at it. It has a lot of things about insurance reform, everything from Medicaid expansion to the creation of exchanges, to getting kids under the age of 26 on their parents' policies. And it has a lot of interesting delivery system reform issues, ACOs and bundles, all the way down to federally qualified health centers. We're going to talk mostly this evening about the insurance reform issues. If you're interested in getting into talking about some of the others, maybe we can do that in the question or answer or afterwards in discussion. So, what did we get? Essentially a mandate model. Everyone is required to have health insurance or pay a penalty. And the individual mandate will rise to a penalty of $695 for single individuals in 2017, and for families, $2,085. You probably read in the newspapers that this is the first year when these penalties will go into effect. And in fact, this year it's only $95 if you didn't have insurance in 2014. In other words, when you file for your taxes this year, you're going to have to check off something that says you have health insurance or you don't. And if you didn't have it in 2014, you'll pay $95 as an individual. And there is an employer mandate in this legislation. If you employ 50 or more people and do not offer health insurance, then you as the employer will have to pay $2,000 per employee to the government because you don't offer health insurance. And I think that this kind of mandate was, frankly, absolutely essential for the survival of the private health insurance industry. Lewin and Associates gave us the data, right? A lot of people would have left the private insurance industry for the public option, had there been a public option. And even now, with a mandate, people are being forced, in essence, into buying private health insurance. And why is that? Frankly, because I think private health insurance is a defective product. And fewer people by 2009 were actually buying it. In 2009 alone, you can see 6.3 million people had given up their private health insurance. Why? Probably heavily because of the economic crisis of 2007 and 2008, yes. But if you go back before that, for the decade before that, 15 million people had already given up their private health insurance, did not find it worth buying. So, and what we're going to do this evening is compare that approach to what I call an improved Medicare for all, or a single-payer model for healthcare reform. What would that be? Well, one would build on the original Medicare program, expand it to the entire population, improve its coverage, because when it was created, Medicare did not cover a lot of preventive services. In fact, there were very few randomized trials back in 1965 that justified, preventive services. It didn't cover dental care, and it really didn't cover long-term care, except for 21 days in a nursing home after a hospitalization. It would eliminate deductibles and co-payments, and we'll talk about why one would do that. Expand drug coverage, so it would eliminate the donut hole in the drug benefit, and have real public administration. And yes, we could begin to talk about redesigning physician reimbursement. So what we're going to do now is take these challenges facing our system and compare how the ACA addresses those challenges and how a single payer could address them. And so let's start with the first one, declining access. And indeed, if you look at the data, it's kind of fascinating. When you look at this, it's about 1 million more people uninsured every year since 1976. Yes, there's a little dip here in the middle of the 1980s when Henry Waxman got his Medicaid expansion passed through Congress. A little dip here at the end of the 1990s when the state child health insurance program was created. And indeed, a little dip here around 2011-12 when in fact children could, through the ACA, be insured under their parents' policies up to age 26. But fundamentally, we have a huge problem with access to care in terms of people being uninsured. But I think this is only part of the problem, because I think there is indeed an epidemic of what I call underinsurance. And underinsurance, my definition is rather simple. If you spend 10% of your income on health care in any one year, you don't have enough insurance. You just don't. And back in the year 2000, you can see there were 42 million people who had that experience. And they weren't just people who didn't have health insurance, okay? They were people who had health insurance. But the health insurance didn't cover all of their expenses. And that number had gone up to 62 million here in 2007, and is probably now close to 80 million people who are underinsured, still paying 10% of their income on health care. Little wonder that 62% of all bankruptcies in the United States, personal bankruptcies, are due to medical care, medical debt. And 75% of those people had health insurance at the outset of their bankrupting illness. Why did they go bankrupt? Anyone have an idea?
Not enough.
Yeah, they were underinsured, right? Not enough insurance. But there's another reason. Prior to the ACA, what do you imagine happened? Someone got sick enough that they lost their job, and what happened? They lost their health insurance. And is there any private insurance company that would have in fact picked them up after they had lost their insurance because they were in fact sick? No way. And I think this is why you see this kind of number. Well, how does an improved Medicare for all deal with the problem of access to care? The first thing is, you really should look for the language, is there automatic enrollment? Okay, you present to the emergency room of a hospital. They do their wallet biopsy on you and they find out you have no health insurance. What an opportunity. Let's sign you up right here in the emergency room because you deserve to have health insurance. Is there any private company that would, insurance company that would sign you up in the emergency room of a hospital? No way. That's the difference here. Automatic enrollment. And yes, it should be a federal guarantee. And probably the most controversial thing I'll say this evening is that I think it ought to, in fact, cover all residents of the United States. Oh, you mean the undocumented? Yes, I mean the undocumented. Yeah, we might put some residency restrictions in there that you would have to prove residency in the United States, you know, for 9 months, 12 months, 18 months. But, so people wouldn't just come here to get the health insurance, right? But I think it's really important from public health and humanitarian reasons to be covering even the undocumented. Everybody in, nobody out.
What about emergency Medicaid?
What about emergency Medicaid?
Yeah.
Well, it's one way in which, depending again on the state, you know, there are no federal dollars in emergency Medicaid. You realize that? Who pays for emergency Medicaid? State taxes, right? And so there are many states where there's no such thing as emergency Medicaid, right? What does the ACA do? Essentially, in terms of access, yes, it mandates the purchase of private health insurance. That went into effect last year. It expands Medicaid eligibility up to 138% of the federal poverty level, and 138% of the poverty level is, $15,856. Try to live in New York City on that amount of income. Or families up to $26,900. But as you all know, there are 24 states that have refused to expand Medicaid. Now that number is beginning to erode because some of those states that refused it at first are now saying, this was supposed to be all federally subsidized, 100%. And they're beginning to realize that maybe they made a mistake. But, and then there's this whole subsidy of premiums up to 400% of the poverty level. And here you see incomes that are much more respectable, and that probably, in fact, apply to substantial portions of our population. And yes, then there are some insurance market reforms, coverage up to age 26, no pre-existing condition exclusion for that person who loses their job because they, in fact, gone sick, and no annual or lifetime limits. Any questions about this aspect of the ACA? Well, what effect do we think it's going to have? Here are estimates made by, frankly, the ACA in 2010, the ACA post the Supreme Court decision not to expand, allowing states not to expand the Medicaid program. And what you see is that by 2019, we will still have 29 million people, it is estimated, who will remain uninsured. The ACA does not guarantee automatic enrollment, essentially, or guarantee that we will, in fact, have universal coverage in the United States. Okay, well, what about the problem of costs? That was the other reason that President Obama was so interested in getting health insurance. And indeed, what you see here is that there is a major problem. If you look at the health insurance premiums, they went up from 1999 to 2012 by 172%, and the employee contribution to the premium went up even more than that, 180%, so that in fact people's salaries were going down because they had to literally buy more or contribute more to health insurance. And here you see the average worker's earnings only went up 47%, and inflation took away roughly 38% of that increase. We had a real problem with the cost of healthcare insurance. And here from the Kaiser Family Fund, what you see is that single coverage, on average, for employer-provided health insurance, and in New York, this is low. It's even more expensive in New York. But this is the kind of cheapest insurance you can get through the employer because the employer can negotiate directly with the health insurance industry for lower premiums, whereas an individual really can't do that. And what you see is $6,025 for single coverage. Family coverage is now up to $16,800, and the employee contribution has gone up to over $1,000 for a single person, and for a family close to $5,000. So this is really, we have a cost problem. President Obama was absolutely right. How does a single payer, Medicare for all, deal with this problem? Largely through being a single payer, it gets low administrative costs. Compare the Medicare program which has an administrative cost of 2 to 3%. And what I mean by administrative cost is essentially the dollars kept that are collected for the program, that are kept to run the bureaucracy of the program. That means that in the Medicare program, of the dollars collected, 97 to 98% of those go out to pay doctors, hospitals, prescription drugs. In private insurance, that amount that is kept for administration is essentially 16 to 30%. That's both administration, by the way, and profit. In this article, recently published, last year, it is estimated that $375 billion could be saved if we converted from our for-profit private health insurance program to a Medicare for all or single-payer program. And that amount of money could probably cover everybody who doesn't have health insurance today, and in fact, improve insurance for those who are underinsured. Where does that money come from? Here's a study by Lewin and Associates, that group that estimated the 119 million people. And what you see is that indeed it costs more if you're going to cover everybody who's uninsured or poorly insured. And if you eliminate cost sharing and copays, it costs more overall, 11.5%. But the savings you can get are not just from health insurance company administrative costs, but because every hospital has to have a staff to deal with the multiple insurance companies, each of which has their own, prior approval mechanism, their own rates, and so on and so forth. We compared, for instance, Toronto General in single-payer Canada with the Mass General, similarly sized hospitals, and what we found was 3 billers up there in Canada dealing with, billings and collections, and over 300 at the Mass General. One could have an amazing reduction of costs if one went to single payer. And that would be true in physician offices, where I need additional people in my office to challenge the denial of claims that come from private health insurance companies, that in fact, if I want a prior approval, I need a staff that knows how, Empire Blue Cross is different from Aetna in terms of what they require for that. So I could, really reduce my staff. We could do some bulk purchasing of drugs and equipment. What entity in this country gets the lowest price for prescription drugs? Anyone have an idea? It's not Medicare, because Medicare is by law not allowed to directly negotiate for price. Did you have an idea? The VA. Absolutely correct, right? Why? Because it can negotiate directly with the pharmaceutical industry for the price of drugs. And finally, we could really think in terms of a primary care emphasis, and everybody talks about reducing fraud. So the total savings amounts to 15.8%. We could literally save money in our healthcare system if we converted from multi-payer to single-payer. And this slide illustrates some of how that might happen. Here you see the increase in the number of docs that our system has produced, and the increase in the number of administrators. We need to amputate that group, give them meaningful work instead of, denying claims and pushing papers. Let's think of a more creative way of using that workforce. And just to show you, this isn't just my data, okay? Here's Carl Schramm, a conservative economist who agrees that Medicare's overhead, administrative costs, and so on is about 3.1% compared to commercial for-profit insurers, which was 19.9% in his estimate. That's what made me think he's really conservative. He wouldn't say 20%. Right? And when a nonprofit blue becomes an investor-owned or for-profit blue, its administrative costs again rise. And single payer offers a number of ways in which we could control costs over the long term as well. And some of these we could talk about in the question period, the whole notion of global budgeting of hospitals, much more capital investment planning, an emphasis on primary care and the coordination of care and alternative ways of paying for care, and the bulk purchasing of pharmaceuticals the way the VA does. Well, how does the ACA deal with this problem of cost? Fundamentally, it's a market-based system, right? The idea behind the ACA was if we can mandate the young, healthy, uninsured buy private health insurance, you know, they're what we call the invincibles. They never believe they're going to get sick, right? And so they don't get health insurance. If we could mandate that they buy it, since they don't, in fact, get sick, right, they're low risks, it ought to be possible that premiums for everyone would go down. Well, will this really work? I just told you what the premium costs on average are, and what the penalties are. And I think there's a real question about whether or not these penalties will be sufficient to, in fact, get people to buy private health insurance, as costly as it is. And the ACA offers a number of tools, you know, that are supposed to contain costs, but none of these have really been submitted to good randomized controlled trials. For instance, the whole notion of health information technology, yes, we ought to have electronic medical records, but to set those up in every office in this country and in every hospital is an expensive task. It's going to cost money at the outset. It's not going to save money at the outset. Chronic disease management, the approach that Ed Wagner created out on the West Coast in Portland, Oregon. Again, a great idea, but will it really save costs to manage people's chronic diseases? Well, we will see, but it hasn't been shown yet, I think, to do that. And yes, then there are these different payment reforms that you may have heard a lot about, or heard nothing about, depending on where you're from. ACOs, bundled payments, value-based purchasing. Interesting ideas, but never, I think, truly submitted to a good trial in terms of saving costs. And little wonder then that, indeed, you know, the CMS actuary, the Congressional Budget Office, the Commonwealth Fund, which is a strong advocate for the ACA, all of them estimate that the growth rate in our medical costs is not going to, in fact, mitigate that much, such that by 2019, we will be up to $4,670 billion being spent in healthcare, maybe close to 21% of the gross domestic product. Now, these are somewhat old numbers, that's correct, and there has been some mitigation of cost increase the last 2 years, but we're still way above the growth in the GNP, and everyone is predicting that, in fact, this coming year we're going to see a much greater increase. Well, what about the lack of comprehensive benefits? Okay, here's an interesting territory. Whenever you think about benefits, don't only think in terms of the services that are covered, like doctors, nurse practitioners, hospitals, and so forth, but also think about the financial coverage, okay, co-pays and deductibles. In a Medicare for all single-payer system, we would want, in fact, the broadest coverage possible. All medically necessary services. Would there be any exclusions? Sure, tummy tuck, Botox for wrinkles, but I'd like to keep them very limited. Well, probably even private rooms in a hospital. I'm in a room with you in a hospital, and you're coughing away, and the resident comes in and says, I think you might have tuberculosis. Ooh, get me out of his room. He has a medically necessary reason to have a private room. That should be covered. How would these things be decided? Very complicated question. We could go into this, but I would like to see some kind of coverage board that in fact included physicians, hospital administrators, but more importantly, patient representatives, so that in fact coverage issues could be addressed. And I would eliminate co-pays and deductibles. Why? Because they reduce the use of needed and unneeded services virtually equally. Every study seems to show that. And they result in the underuse of primary care, and frankly, I don't think they're as effective in reducing the overuse of technology-intensive services as some of these other approaches, eliminating self-referral to MD-owned facilities. One of the reasons that Atul Gawande's article on McAllen, Texas, which showed that it was the very expensive area, in terms of Medicare reimbursement. The reason I think for that is that all the MRIs and the CT scanners and so forth were owned by the docs in that community, and they were self-referring and reducing defensive medicine. Now, you seem to have a question.
Yeah, I noticed in your last slide you mentioned dental services.
Yeah.
And that's something that I haven't heard much about in a lot of our discussions around healthcare reform. Can you talk about kind of why your proposed plan of the Medicare for all single-payer model, why dental care will be included, and kind of what are some of the implications of that?
Well, I think, basic health care should include dental care. One of our real problems in this country now, ask people how many people have a really good dental health insurance program. Usually when I'm in an older audience, nobody raises their hand, okay? And yet, dental care, it seems to me, is fairly fundamental to people's sense of well-being, their ability to perform in the society. For younger people, if you don't have teeth, you're not going to get promoted, frankly. So I think it's an important dimension of things. And it gets even more important as people get older, for instance, and have diabetes and, the risk of infection and stuff like that. So I think dental care is really very important.
And from a cost perspective, how would that affect kind of this model?
Well, my sense is it's not going to be the thing that breaks the bank. Okay? It just isn't that high a percentage of our overall healthcare costs. How does the ACA deal with this issue of comprehensive benefits? Well, frankly, there is no standard benefit package in the ACA. Oh yes, the IOM said that there were 10 areas that each insurance had to cover, so that things like prenatal care, pediatrics, as well as hospitals and doctor fees, things like that, categories, but no truly standard benefit package. It does eliminate co-pays and deductibles, but only on preventive services. That's a good thing. It stipulates that health insurers must have a medical loss ratio of 80 to 85%. Oh, what is a medical loss ratio? Has anyone heard of that? This is a remarkable insurance company concept, I think. The idea is that from the perspective of the insurer, insurance company, and by the way, its stock owners and so on, every dollar spent on a hospital, on a doctor, on a prescription drug is considered a loss to the company. Oh, but wait a minute, I thought health insurance was supposed to help you get care. But you see it has a built-in incentive not to do that, because in fact, that money then doesn't go to the investor. And so the ACA, a good thing, says we're going to limit the amount that insurance companies can keep to in fact provide dividends to their investors, or to hire staff to deny claims and do paperwork. And the ACA has no regulation of the magnitude of premiums, deductibles, and copays, just the stipulation that benefits have an actuarial value of 60% or higher. What is an actuarial value? Well, here's one description put together by Wellmark, a private insurer. And indeed, these are these metal plans. Have you heard the metal plans described to you? A bronze plan, over here, is one in which the actuarial value is 60%. That means that's what the insurance company pays. You have to pay out of pocket 40%. A silver plan is 70% by the insurance company, 30% you pay. 80% in the gold plan, 20% you pay. A platinum plan, 90%. You pay 10%. So these are the actuarial values, but you can see the bottom point here is that insurance companies can offer plans that have only a 60% actuarial value. And in the state of New York, just to give you one example, a bronze plan through the exchange in New York, has a $6,000 deductible, a maximum out-of-pocket payment of $12,700, but 50% co-payment on all of these things: ambulance services, emergency department, urgent care, advanced imaging, things of that sort. So, a real problem, again, with what I would call underinsurance. Well, our fourth challenge was, restricted choice, but I thought that, having multiple insurance companies gives you a lot of choice. But 42% of employees in this country have no choice. These are employees who are insured. Why do they have no choice? Anyone have a guess? Pardon? They want to keep their job, that's true, and they don't want to lose their health insurance, if they lose their job or change their job. But the major reason here is that the employer offers how many plans? One plan. I don't call that choice for 42% of people. And private health insurance, frankly, limits your choice to a network of doctors and hospitals with whom the insurance company has negotiated contracts. Again, limiting people's choice. And if you go out of network, in fact, you pay substantially more. How does a Medicare for All deal with this problem of choice? Well, it expands choice for everyone, I would argue. There would be no limit to a network of providers. There would be free choice of doctor and hospital. We would finally join the rest of the industrialized nations of the world and de-link our health insurance from employment. That is a real goal. How does the ACA deal with this problem of choice? by creating these things called health insurance exchanges. My argument here is that they essentially expand choice, yes, for some people, but not for everybody. Enrollment is limited to those in the individual and small group market. Yes, it creates a marketplace of private health plans, but there is no public option. These are state-based largely, but no standard national plan. Oh, yes, we do have a federal, exchange that people can buy into. And there's no state single-payer plan allowed until 2017. Well, I'll tell you, frankly, in the state of New York, here's Richard Godfrey, the chair of our Assembly's Health Committee, and he has a single-payer bill that he has proposed in the state legislature. And last year, we had enough co-sponsors to pass that bill, but we didn't have the speaker's permission, essentially, to introduce it. Here in the state of Rhode Island, there is a bill that is likely to be introduced sometime this year called the Comprehensive Health Insurance Program, Rhode Island CHIP, essentially, which has all the features of a single-payer approach. Universal coverage, comprehensive benefits, coordination of care, but no gatekeeping, no co-payments or deductibles, no private insurance that duplicates the public coverage, and funding by a graduated payroll tax. And in fact, when this has been submitted to an economist, Gerald Friedman, now chair of the Department of Economics at the University of Massachusetts, he shows you what a progressive payroll, he calls it premium, which is probably smart politically, what it would look like, okay? He argues that for people with average incomes of around $22,000, it would be a 5.6% premium, and that it would go up to 8.6% for people with incomes over $1 million. And most people would actually save if, in fact, this kind of a single payer was put into effect. Whereas people with incomes over, $466,000, they would be paying more than they presently pay in terms of premiums and so forth. And yes, certainly people over $1 million. The value, interestingly, in a state single-payer program or in any single-payer program of talking in terms of the payroll premium is that it really does allow individuals to go home and just do the math. How much is this going to cost? And then what one needs to do is to talk in terms of, what part of that payroll premium is going to be paid by the employer and what part is going to be paid by, the patient or the enrollee. Our fifth challenge is uneven quality. In 2014, the U.S. was the last among 11 industrialized nations in health system performance. This is from a report by the Commonwealth Fund called Mirror, Mirror on the Wall. And we had gone backwards from 2004 when we were 5th rather than 11th. What does an improved Medicare for all offer in terms of quality? Well, first, we would have a national database. I don't know how many of you looked at quality studies out there. They're usually done on Medicare data. Why? Because it's a national database. Private insurance companies regard their quality data as proprietary. And believe me, they do not put out data that shows poor quality because then people wouldn't buy their health insurance, right? Well, we need a national database with national standards and public reporting. And frankly, I'd like to see everybody get a little credit card, with all of their medical data on it. blood pressures, EKGs, the last, blood sugar, hemoglobin A1Cs, a description of their last hospitalization. All of that is possible in a single-payer national health insurance program. Last year I went to Taiwan, and that's what they had. And the patients just love it. They pull out their card and show it to you. The interesting thing is that they've also thought about this in terms of privacy, so that if you lose your card, there's no way that just anybody can go out there, pick it up, put it into a machine, and find out what your health status was. You need a matching card. Usually only doctors have them to get the data out of the system. So that could be done. Well, what does the ACA offer in terms of quality? Yes, comparative effectiveness research, an innovation center in CMS to test new payment and service models, value-based purchasing, readmission penalties, and hospitals, reducing hospital payments for hospital-acquired conditions. Good things, but frankly, I think not sufficient to really bring our system up to the quality levels of other industrialized nations. The sixth challenge is insufficient primary care. 84% of our 2014 graduates have educational debt from medical school. And the average debt is $176,000. You guys know that better than I do, probably. And primary care is essentially under-reimbursed. Little wonder that most of our medical school graduates these days are going into specialties. How would an improved Medicare for all deal with this? I think this is speculative, but I would like to see us really begin to talk about reduced or free tuition to medical schools. And I would see how one could do this, frankly, using GME monies, graduate medical education monies, to move in this direction. Not going to, because of the time, deal more with that. Debt forgiveness for people who go into primary care, that I think is pretty simple. We really ought to do that. We do it now for people who go into federally qualified health centers, so it's not so difficult to think it wouldn't happen. Malpractice payment for people who go into private, into primary care, again, something we do in the FQHCs. And yes, we could really talk about patient-centered medical homes. What does the ACA do in terms of primary care? Yes, it puts in a 10% primary care bonus, but when we've done an estimate of really how much that is going to be, it's only $4,000 to $10,000, per practitioner. I don't think that's enough to induce you to go into primary care. Increasing Medicaid payment to the Medicare rates for primary care, a very useful thing, but in many states now being rolled back. And there's this creation of the Independent Payment Advisory Board, the IPAB, which has not moved ahead. It was supposed to be created in 2014. And interestingly, Obama has decided not to move on that. And finally, there's the question of how you pay for reform. And in a Medicare for All system, frankly, you use public funding. A graduated payroll tax, not the flat tax that we presently have. Does anyone have an idea of how much do you pay if you had a job for Medicare right now? Everybody pays something into the Medicare program if you're employed. Anyone have an idea? It's 1.45% of your income. Your employer contributes 1.45% for a total of 2.9%. The problem with it is that it's the same for the lowest paid worker in the company as well as the president. We want to see a graduated payroll tax, such as in fact is being proposed here in Rhode Island. And yes, there are other sources that we could go to, corporate taxes, going into the income tax territory, a tax on unearned income, such as stocks and bonds, even landlord rents are considered unearned. But I'd like to get away from the concept of premiums, because premiums are in fact regressive. The president of the company pays the same premium for health insurance as his secretary or her secretary, and yet their incomes are so widely different. And as I think I've demonstrated, there'd be no increase in the overall healthcare spending because of the administrative savings in a Medicare for All approach. This is not, by the way, socialized medicine, okay? Socialized medicine is a situation like the UK or Denmark or Sweden, where doctors are employed by the federal government and hospitals are all owned by the federal government. That's why some people say, I'm much too conservative, right? They would like to see a national health service in the United States. That actually was the position that Arnold Relman took before he died, former editor of the New England Journal. But that's not what we're talking about. We're talking about what I call a publicly funded but privately delivered system. This is not socialized medicine. How does the ACA deal with the question of paying for things? There is the increase in taxes, particularly the Cadillac tax on health insurance plans. What does that mean? Well, it means that those plans that, in fact, have an actuarial value in the high 80s or 90s are going to be taxed additionally. So what will happen to those plans? They'll all have an incentive to, in fact, go into the gold level or silver level or bronze level, where their actuarial values will be lower. Not a good thing. That doesn't happen until 2018, so I think we'll see a lot of things. And then there's savings from Medicare. We're running out of time, so I'm not going to dilate more, but the ACA funding is not that exciting, frankly. So, in summary, what do you get in the Affordable Care Act? Expanded coverage, but not universal coverage. Cost control by market means, no definition of benefits, frankly. Risk of increasing underinsurance. Choice through state-based exchanges, but no public option. Primary care and ACO pilots. And funding through an excise tax on high-cost comprehensive private health insurance and Medicare cutbacks. What do you get with a single-payer approach? This is our physician's proposal from 2003, a little bit out of date, you might say. We have a new one, and it should be, in fact, out in the next 4 or 5 months. And what you get is essentially universal coverage through automatic enrollment, low administrative costs because it's a single payer, comprehensive coverage without copays and deductibles, maximum choice of doctor and hospital, improved quality through nationwide HIT, expanded primary care, publicly funded and privately delivered. The Cornell students have all told me I should call this Medicare 2.0. And we have a bill in Congress actually being introduced sometime next week, we think. H.R. 676, that is a single-payer bill. We have one in the Senate called Senate 1782. And it's fascinating when you go out and do a poll. Here's a poll done just a month ago by the New York Times and CBS, not by me. And what they asked is, would you favor or oppose a government-administered health plan, something like Medicare coverage that people who are now 65 and older get, that would compete with private health insurance plans? So that's not a single payer. But 59% of people favor this kind of an approach, and only 34% oppose it. and 8% had no opinion. And the second question does address the single-payer question. Would you favor or oppose a single-payer health care system in which all Americans would get their health insurance from one government plan? And you can't see it down here, but this is, I believe, 43%, yes, of people favored that. Well, that's fascinating, right? We only have to take, 7 of these no-opinion people and get them over here to get 50% of people favoring this approach. And maybe even try to get a few of these people who are opposed to see the value of the single-payer approach. So, a system based on private health insurance plans will not lead to universal coverage, will not create affordable coverage. A Medicare for all system, I think, can lead to universal comprehensive coverage without costing more, has the greatest potential to increase choice, improve quality, and expand primary care, and can be financed fairly, okay? What will happen if we don't do this? Here you can see the average household income and how it's going to increase in the United States over the next 2 decades. But here what you see are the costs of health care in the United States and health insurance, such that by 2038, a person's entire household income will in fact have to pay for health insurance, a condition that's not compatible with life. So at an end of a talk like this, everyone asks me, is the ACA a step forward or a step backward? And I understand the perspectives that say it's a step forward, because it does expand coverage, through Medicaid expansion, subsidies to buy private health insurance. More people are going to get health insurance, and that's good. But I understand people who say it's a backward movement, because it gives taxpayer money to private health insurance companies, which are going to be the major opposition to moving toward a single payer. So I believe the ACA, frankly, is a great leap sideways. There's no question we must go beyond the ACA to a single payer system. And I like this paraphrase of a quote by Martin Luther King. He said, the arc of history, he said, the moral universe, is long, but it bends toward justice, he said. I believe it also bends towards access to health care for all. Here are a few references that I think are really useful. You should actually consider signing up for, getting some email messages from PNHP, Physicians for a National Health Program. But the other thing you really should consider doing if you're interested in policy question is to go to Quote of the Day, which you can get without any cost by going to the PNHP national website. Look for Quote of the Day, and what you get there is, probably 1 or 2 emails a week on health policy topics from Don McCann, who gives you the data that is presented and then tries to critique that from a single payer perspective.